My name is Barbara Cherry, and I'm on the Program Planning Committee for ALSN, Association for Leadership Science and Nursing. I am also the immediate past president, and so we do these hot topics just to give us all a chance to come together and talk about some really important work that's going on in the nursing world. This one's especially relevant for us as nurse educators. We're happy to have Dr. Beth Swan for this presentation. She is a professor at the Jefferson College of Nursing at Thomas Jefferson University in Philadelphia. She did her PhD at the University of Pennsylvania, her MSN at the University of Pennsylvania, and her BSN at Holy Family College. She also did a postdoctoral research fellowship with Robert Wood Johnson, and her research and clinical interests are care coordination and transition management, ambulatory care, the role of RNs in ambulatory care and primary care. And I won't read them all because she's got a long list, but there is a connection there, a link at the ALSN website to see all of the amazing work she's done. So Dr. Swan, we are very happy to have you, and please take it away. And just one more thing, as she goes through her presentation, please keep in mind questions and comments so that we can have a discussion once she's finished. Dr. Swan.
Okay, thank you, Barbara. I appreciate that. Can everyone hear me and everyone can see the slides? Okay, so just to get started, so I just want to say good afternoon, and again, Barbara, thank you for the opportunity to be with you today. The article that's being discussed during the webinar was the result of an invitational summit and focus groups on care coordination and transition management. And I would like to acknowledge Dr. Sheila Haas, who is my longtime collaborator, partner in crime, and also like to acknowledge Dr. Regina Conway Phillips, who was the qualitative research expert who worked with us, and one of her doctoral students, Laura Della Penna. So I just want to acknowledge the team who worked on this. So just some background before we jump into the recommendations is, so we convened an invitational summit in May of 2018 on care coordination and transition management. And the goal was really to create a common platform to facilitate adoption of the role of the RN in care coordination and transition management. We really were focusing on addressing the acute and chronic care needs of individuals, enhancing quality and safety and decreasing cost, integrating competencies into academic and ongoing education, and then developing a plan to really embed the role into practice, healthcare policy, and payment reform. And as we looked at the role of the RN, we're looking at it in its broadest sense. So we believe that care coordination and managing transition is really part of the role for any registered nurse, whether the registered nurse is a staff nurse working at the bedside, whether they're in primary care, ambulatory care, a dialysis unit, wherever, each registered nurse has these activities, if you will, in their role. So prior to the conference, invitees were asked to respond to an online survey, which I'm going to share some results with you. There were 43 invitees, 35 participants completed it for an 80% response rate. We also asked participants to read 4 publications, and the full citations for each of these articles is included on slide 18. And I guess I should just stop here. So Barbara, participants in the webinar today, they'll have access to the slides.
Pat, can you answer that question? Will the participant, yeah, I'm sure we can make the slides available, yes, with your permission.
Okay, because I did send them
Yes,
as a
we can.
I did send them as a PDF, and you're happy to share those with people on the webinar today.
Okay, thank you.
Okay.
Okay.
Can we also share on the website for anybody else who wasn't able to make it?
Sure, that's fine.
Okay, great.
Okay. And so with the summit, with the pre-summit survey, we were surprised to find that actually 76%, the majority of our respondents were familiar with the care coordination, transition management core curriculum, and that close to 70% had experience with implementing CCTM. And they listed, the respondents listed some of their successes as increasing patient activation measures, improving metrics for chronic disease, increasing patient satisfaction, and decreasing emergency department and hospital utilization. And so we also asked on the pre-summit survey, what are some challenges that people have experienced in implementing the role of the RN in care coordination and transition management? And some of the challenges are listed here. I'm not going to read them all, but I will point out a few. So one big one that was listed was, electronic health records, and that oftentimes the documentation is challenging if you're using ACO tools or some of the care management tools in the electronic system. The lack of the longitudinal plan of care and the ability to look at outcomes, both short-term and longer-term outcomes, and this whole notion of the workflow to really support care of individuals across the continuum rather than in a single site of care. So they were really the main challenges. And then some of the barriers looked at, measuring the impact, justifying the RN staffing for care coordination, and also, again, I'll mention the lack of the interoperability across the continuum. And some continued barriers, we see the EHR repeatedly. Some have to do with the fear that if the RN is coordinating someone's care, that you're taking something away from your colleague in home care or potentially, skilled nursing. So this notion that we need to be more cognizant of is it's across the continuum, and RNs across that continuum really should be collaborating and working together for the individual's care and better outcomes, rather than being concerned about, who might be taking a patient away. Some other barriers had to do with time and prioritization of the care coordination within the role, the lack of awareness, or that people really didn't see the perceived value or recognition, and then really the need to include care coordination and managing transition as part of a job responsibility, so it's more recognized. So after we presented the results, we shared several summit exemplars. And again, I'm not going to read this, but Mary Beth Edger from Thomas Jefferson University Hospital shared the implementation of the CCTM with acute care nurses as it relates to improving nurse communication and the score on the HCAHPS. And that was implemented with 300 nurses on acute care units. and showed, an increase in the nurse communication scores. A second exemplar was shared by Kathy Mertens from the University of Washington, Harvard View Medical, and really looking at patient activation measures and using care coordination competencies to really increase the activation and improve outcomes. And then Fran Vlasis from Loyola presented her work from an interprofessional perspective on the experiences of interprofessional students looking at care coordination across in caring for diabetes patients, diabetes and hypertension. And then the fourth exemplar was presented by Rachel Start and Diane Brown. And this really looked at the overview of the collaboration between the American Academy of Ambulatory Care Nursing and CalNOC, the Collaborative Alliance for Nursing Outcomes. And this exemplar was presented to really be able to address some of the challenges and barriers in identifying and measuring outcomes from care coordination. And so the focus of the collaboration really is looking at ambulatory care nurse-sensitive indicators and linking them with care coordination and managing transitions to outcome measures. And I want to note that in March of 2019, Press Ganey acquired the CalNOC database of nurse-sensitive indicators. So they saw that as a good thing to be able to continue the work of advancing patient care excellence, and also being able to bring together those acute, very well established acute care nurse-sensitive indicators and now have an ambulatory care set. So I wanted to mention that because that's developed within the last 6 months. And so then just as a way to be sure, we did have Institutional Review Board approval. We did have verbal consent of all the focus group participants. And Sheila Haas and I developed a discussion guide, and we recorded everything. We had digital recorders, we had note takers, so that we were capturing all the rich discussion that participants offered. So for the focus group related to nursing education, we were really looking at discuss the barriers to adopting this in nursing education. What would strategies be used to overcome the barriers? Who were the major stakeholders? What strategies could be used to bring the stakeholders in as collaborators? And what could be used as perceived incentives and benefits? So that's the next few slides. We'll share this briefly. So the focus groups actually identified 57 barriers that we organized into 4 key categories. One had to do with curriculum redesign, the silos of care settings and care providers, the knowledge gap among faculty, and also the need for faculty development to really overcome resistance in moving from a very acute care focused curriculum to one that opens itself up to looking across the continuum to primary care, ambulatory care, and other sites of care. And we looked at 4 key strategies to overcome the barriers, looking at offering resources to integrate this content into the curriculum, collaboration, dissemination, and then the role clarification of the RN for our students and also practicing nurses, and also changing that culture within nursing education to move beyond a sole focus on acute care. So our focus group participants identified over 40 stakeholders, 18 internal to nursing, 23 external to nursing. Some of the internal to nursing will be obvious to all of you. Nursing deans, faculty, AACN, NLN, chief nursing officers, chief nurse executives, vice presidents for education and research. And there's many, and then 23 external stakeholders included, employers of RNs, practice partners, C-suite executives, and the list goes on. But ideally, these stakeholders can be engaged to be part of the solution in addressing barriers to adopting care coordination and transition management roles for registered nurses. Overwhelmingly, the incentives and benefits of adopting CCTM really looks at impacting the care experience and improving quality of care. So that focus on patient person-centered care, and also developing a better prepared workforce. So some of the recommendations had to do with a branding campaign, a dialogue series among nursing leaders, faculty, students, and other healthcare providers that are essential to curriculum redesign so that we can move beyond concern for care for the encounter or the stay to care that's provided and coordinated across the continuum. We also looked at enhancing academic practice partnerships, again, moving beyond agreements between academe and practice to provide sites for student clinical experiences, to really looking at broadening that collaboration between academics and service leaders in looking at preparing new graduates to meet the demands for care across the healthcare continuum. So as the Affordable Care Act provisions are still being employed, accountable care organizations, patient-centered medical homes, all these models of care that are part of the value-based purchasing from volume to value are really key to keep people out of the hospital and also achieve those incentives that hospitals have tied financial incentives for. And the need that in nursing faculty, our students really need to be prepared for that kind of healthcare delivery model. And that really includes knowing how to coordinate care and managing those transitions that people will absolutely have when they interact with the healthcare system. So that was a big one, kind of refocusing that lens and really looking at your academic partners and saying, okay, what have you been doing in healthcare delivery that really we could join up with you on behalf of our students beyond the traditional acute care experience. The need for ongoing faculty education and development, and then the idea to create an academy model where faculty could participate in a quote academy, and then they could then go out as the ambassadors or the faculty training other faculty on why this is important. And so these are the references that I mentioned for the pre-summit readings, and then these are the publications from the Invitational Summit. And 21 minutes, I had 20 minutes, so there we are. Let me just go back. Yeah. Okay, let me get to my last slide there. And so now we have time for questions. So I see a lot of people with their mute buttons on, so perhaps if you want to unmute, we can have questions, discussion, whatever you'd like.
Thank you, Beth Ann. I actually have a question. This is Barbara, and I have a lot of questions, and I hope other people will jump in here, but I'll start. So how did you know, the model itself, I mean, it speaks for itself and how successful this would be, especially for people with chronic conditions like diabetes and hypertension and congestive heart failure. But how, can you talk about the barrier? Say we decide to adopt this in our curriculum, finding sites that actually have these positions and nurses functioning in this role to serve as preceptors or to give a clinical experience to students. How did that work?
So I can speak from my experience at Jefferson, and because in 2016 we created a whole new curriculum, moving away from acute care. So students were looking at promoting health and quality of life across the continuum. And so we had a variety of things we created. So one was, identifying RNs in what I would call traditional primary care or ambulatory care role. We also looked at opportunities for students in accountable care organizations. So they had that experience of, oh, okay, this is how registered nurses are really viewing a population versus an individual person. And so they had the opportunity to have some experience at an ACO. We do have some students embedded in patient-centered medical homes in practices. The other opportunity they have, on some of the units where there are registered nurses, there's an RN who is based in the outpatient office. For example, oncology, they may have an RN based in bone marrow, and on the nephrology floor, somebody is in the outpatient office. And so when people are leaving the hospital and they have to follow up with either their primary or their specialty care, there's an RN in the office coordinating that. And our students have that opportunity. The other thing we've done is we've really looked beyond traditional opportunities. For example, food pantries, homeless shelters, churches that serve meals, and have worked with the organizations to say, well, what do you need, or how can we help bring healthcare, health promotion to the people that you're serving. And so in that case, we actually have that's a place that doesn't traditionally have a registered nurse. So we have the RN go with our students to those sites. Now, I'm going to stop there because it looks like I've lost everyone. So are there still people there?
Yes.
Okay.
Yes, I think we're here.
Okay. Everybody disappeared from my screen. I'm not quite sure why. But I'll stop there, and I hope that addressed your question. And if not, ask me more.
Yes, I hope some other people have questions.
This is Emily Merrill, and I'll jump in here because I thought that your question was good, Barbara, because I guess everybody can hear me, right?
Yes.
Okay.
Yes.
In one of the only ACOs in our region that I'm very familiar with, I mean, they're very fortunate to have one RN who is the nurse manager. and to think about how, what kinds of experiences, those barriers that Barbara brought up, I think that's going to be the thing. This is going to be so different because there's so few registered nurses in ambulatory care, in my experience. And now they're using so many MAs, and I see the need, but I also see the challenges. There's not a question there. It's just, I'm glad to know that this is at least being looked at and thought about, and some alternate ways of getting those experiences.
Yeah, I think this work is so important because we really have to find ways that we get our students out of the strong focus on the acute care setting. This is one reason we wanted to sponsor this webinar, because Beth Ann is one of the, they have some excellent publications about this exact issue. And I think when we see the new Future of Nursing report come out, the 2020-2030 Future of Nursing report from the National Academies, I think it's going to be a strong focus on how we're working with people out in communities versus just in the acute care setting. Does anybody else have comments about what they're doing or what they think about how we can promote this in nursing education?
Barbara, I'm thinking about the patients who suffer with mental illness and how that applies to this applies to that. Those were some thoughts that I had about. They're also chronically ill patients as well, and we have to manage them. It seems like, and it takes a community, it takes a village, literally, to help these patients out. And I was wondering about that.
So this is Beth Ann. So one thing, as part of our new curriculum, we were fortunate to be able to connect with our City of Philadelphia Department of Health, and all our students and faculty complete the mental health first aid in that first semester, as well as a health coaching program that is offered. And as students move along, they do some work in harm reduction, in trauma-informed care, looking at implicit unconscious bias. So we're trying to keep up with, how can I say, sometimes people think, oh, that means you have to change your curriculum. And so when we've created our new curriculum, we try to make it broad-based as possible. So as new things happened in healthcare delivery, as new things happened opportunity-wise, as other topics were now coming to the forefront, like trauma-informed care and harm reduction, that we were able to very quickly make sure our students were exposed to that and had content in that. And so your point about, mental health is key, because so much of chronic disease and primary care, there's a linkage there between primary and mental health, primary and behavioral health. So again, it's how do we model that for our students so that they're looking at the person in a whole way, and rather than, okay, this disease process or that disease process.
Thank you.
Yeah, excellent points, Beth Ann. I love that all your students and faculty headed to the mental health first aid. You've given me so many ideas to share with our undergraduate faculty. This is excellent. So do we have questions from others? I don't want to dominate, but I do have one more question, but I'm going to let somebody else have a chance. Okay, then I'll jump in here. So Beth Ann, I think one of our major barriers to, because this is such a valuable role for nurses, in care coordination and transition management. But the reimbursement models don't support it fully. So it's hard to get organizations like Emily Merrill said, you know, in ambulatory care, there may be, you know, there's the RNs are few and far between sometimes. So how do you see the reimbursement models possibly changing to support this role in nursing?
Well, I'll let you know. One of our third article really looked at the business case and the value of the role. And one of the issues we discuss in that article is we know from many national reports that team-based care is, you know, the model for improving outcomes, yet reimbursing team-based care is not even on the radar. And so it's really how do we begin to keep up with what's happening in our delivery models and connecting those with reimbursement models. I know that there's literature on, there are codes for care, for chronic care management and transitional care, TCM codes, CCM codes, and it's tied to the physician. However, it's very rare that the physician is doing those activities. And so at one point there was this push for, you know, the RN and getting that reimbursement, but I think we've come further than that in saying if we value team-based care, then that should be the level of tying those incentives to that rather than the individual physician. So I know we've been talking with folks, you know, is there a possibility for a CMS demonstration to look at this? So I guess time will tell.
That's excellent. And, you know, this kind of ties in. ALSN, we have a group working on a research team working on developing they're doing a Delphi study right now to establish the priorities for nursing research for the next, you know, 5 to 10 years. And I do think these type of care models are going to be one of our top recommendations for research. So maybe we'll get more going on around this issue and get attention. So do we have any other questions from anybody else?
I don't have a question, but I think this is very eye-opening, and I really am glad that I joined because I can see the value of it, and the need is just we have to figure out how to do it.
Exactly. Thank you, Emily. So any other questions? Beth Ann, I just want to thank you. This was wonderful. We are recording. We have this recorded. So we'll probably have a lot more people, you know, listen to the recording and be able to have an impact here. And we are having our ALSN annual conference next week in Los Angeles. And so I don't know if you're attending. I hope I will be there. But if you look at our website, which is nursingleadershipscience.org, you can find information about our annual conference. And it's going to, you know, this will probably be one of the topics, especially when we discuss the research priorities for nursing for the coming several years, you know, in the future. But thank you so much, Beth Ann. We greatly appreciate it. Thank you for sharing your slides.